Okay, so after a short introduction, I will hand over the session to Dr. Sharmishta ma'am. Okay, so shall we start now?
Yes.
So good evening and a warm welcome to all the dignitaries present here. I'm Shreyoshi from Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Clarinet serves as the digital partner for this event, hosted by the All India Ophthalmological Society Odisha. And the focus of today's session is OSOS interactive webinar on ROP. So let's begin today's session, for which I would like to invite Dr. Sharmishta ma'am to take over. Kindly proceed with the talk, ma'am. Over to you.
Thank you, Shreyashi. I would like to request our President OSOS to give a welcome note, following which I'll give a welcome note and hand over to the moderators of this session. Over to
Thank
you,
you, ma'am.
sir.
Thank you, ma'am. Honorable Chief Guest, Dr. B.N.R. Subudhi, Honorable Chief Speaker, Dr. Subhadra Jalali, my co-chairpersons, Chairman Scientific Committee and team, panelists, moderators, speakers, and discussants. A very good evening to all of you, and I welcome you all to this webinar on ROP today. Now I will request Dr. Sarmishta Behra to carry on the program.
Now I'll just take a minute. Welcome one and all to this interactive session on ROP. I will just say 4 lines and hand over to the moderators. In the twilight of a fragile start, tiny eyes hold worlds apart, preterm souls in silent plea, seeking light they long to see. Neonatal whispers pediatric care, hand in hand a tender pair with ophthalmic grace. They strive to kindle flames, keep dreams alive. Today from stalwarts like Subhadra ma'am and all other youngsters, including the other speakers, we have a lot of 5 speakers today. Let us all learn, and we have many participants in this who are looking for forwards to the webinar to learn more about ROP, and I'm sure the program is going to be successful. Over to the moderators, Dr. Sashwat and Dr. Brutendu, to take over the session.
Thank you, Dr.
Thank you.
Yeah.
Thank you, ma'am, and good evening, all. Dr. Saswat, please.
So thank you, Dr. Brutendu. So like today, me and Dr. Brutendu will be the moderators of this interactive webinar session. I would request participants to keep on asking questions. They can also write in this group, the meeting on. So today is going to be a very interactive session, and how should we approach a patient of ROP? To start with, we have Dr. Subhadra Jalali. We all know Dr. Jalali. She is the mentor of all of us. I would say each and every person who is dealing with retina and retinopathy of prematurity knows Dr. Jalali. She is one of the most senior doctors in retina and pediatric ophthalmology in India. Over to Dr. Jalali for his talk, please. Thank you, ma'am.
Hello, good evening. I hope you can hear me.
Yes, ma'am.
Yes, ma'am. You are audible.
So I think that, the journey of ROP is not just the eyes. It has gone a long way from the preterm babies being shown in exhibitions in incubators to now we know that, the babies are going blind, which is something that we all can think of, how we can prevent this blindness. And I'm so happy that all of you are there at the front line, as Madam Sharmishta said, taking care of these twinkling eyes and making sure that they see. So what I want to tell is that there's a 6 Sigma checklist for ROP, which all of us should follow for every baby who comes to us. So what is this 6 Sigma checklist? Most of you know that the airline industry, it is the one which started this 6 Sigma, make sure that each and every flight is safe. And so the airline industry is supposed to be the safest industry in the world. So just let us see how we can extrapolate that. So, so all these children who come to us, we are not there when they were, going to be conceived or going to be born. But we should be aware and we should discuss this with the team members in the, nursing and in neonatology and in the obstetrics. So this is just that, there should be proper assisted fertilization protocols, how they will, how many children, eggs they will keep, how many they will do egg reduction for better care of the babies. Otherwise, they will have twins, triplets, quadruplets, which is not very healthy. Then access to maternal care. So, what is the type of place where these children are going to be born? So that is very, very important to know. And then, of course, we want what is called as in situ transfer. That is, if there is a preterm pregnancy, then the baby and the mother before delivery are transferred to a good place where this baby can be taken care of. So we should encourage that. Then maternal nutrition. So especially anemia correction. So we were the first ones to show in a study in 2006 that what the mother has affects what the baby is. Soon show you that data. But we know that, anemic mothers will have less vascularized retina in baby, and also these babies will have more lung problem. So, so I'm not going into that because we are not there, but we should be aware that the maternal health and where the baby is born and how the antenatal care was given, antenatal steroids and all will influence what the baby will have. But I'm more interested in knowing what we can do when the baby comes, because babies will come from various mothers, various facilities. So at least when they come to us, what we can do to improve. So this is just the data to show that, the babies, this is what the retina baby is born with versus gestational age. So you can see here, the study we published that if baby is less than 30 weeks, almost all of them are born with an immature retina. Whereas if they are 34 or 35 weeks, then they are all having mature retina. But the interesting thing is why babies between 31 to 33 weeks, some of them have mature retina, some of them have immature retina. So normally our teaching is that retina should vascularize only at 40 weeks. But every day in the clinic, we are seeing 31, 32, 33 weeks also coming with fully vascularized retina. But why are some having retina vascularized and some not? That is not very clear. Sorry. And you can see here that we found that maternal anemia had a 9.4 times high risk of having an immature vascularized retina in the same hospital if the mother was not anemic. So, so if the mothers are coming from an anemic background, then they will have more immature retina to bond with. So which babies need this Six Sigma care? I think all preterms who are coming to us for screening and management, except where the retina is fully vascularized. If it's already vascularized, then our role is not there. But if you are going to follow up a patient who has incompletely vascularized retina, especially it is in zone 1 still when you first see and there's no ROP, and others like type 2 ROP, that is mild ROP, which you're going to follow when you're not going to treat. Any baby who you're going to treat and you've done laser, most important if you have given anti-VEGF to any baby. Why this Six Sigma checklist? Because in the eye and in the body, there are many natural factors which will promote the vascularization, and there are others which will impede this retinal vascularization. So if you can improve the natural factors which promote vascularization, then it will add up to whatever you are doing for the patient, follow-up or anti-VEGF or whatever you are doing. So you can see here, this baby was referred to me for treatment. And I saw that this patient has a lot of loops. You see the leg, it looks almost like, the posterior zone 1 is also involved, and there are very abnormal vessels there. So for this, they
And your sound is
treat. I just check the hemoglobin. If we are having any patient, we must look. So what are the 6 things? So I have given this mnemonic WULAM. So that is, we need to team up with the family and the neonatologist, and at every visit we need to 6 factors to correct them and to monitor what is happening. So weight gain, we all know. Then oxygen, lungs and respiration, anemia, asepsis, and most important, the mental health of caregivers. So these 6 things, every visit, we should check and have a checklist that we have checked all these 6. So weight gain, at least 20 to 30 grams per day, the baby should gain weight. So we already know from literature, so many studies are there that poor weight gain is a high risk factor for ROP and for poor response to any treatment. So what can we do as ophthalmologists? We should educate the family, the mother-in-law, whosoever is there, that if the baby is not gaining weight, then whatever we do, it's not going to work well. So express breast milk they have to give every 2 hourly. They must give kangaroo mother care even when they are discharged. And then sometimes they may have to supplement the breast milk. So if the mother's milk is not of a good quality because of her malnutrition or whatever thing, then the baby will not gain weight. Even if you're giving that milk, it will be like water. So you need to supplement that feed, and that we need to talk to the neonatologist. So they know what are the formulas to add to the mother's breast milk so that the baby starts gaining good weight. And of course, if the weight gain is not there, they may have to give parental nutrition, total parental nutrition for various reasons. So the weight gain we should monitor at every visit. We should find is the baby gaining weight. If it is not gaining weight and they're coming from a rural background, maybe the neonatologist or pediatrician or medical officer there doesn't know what to do to make this baby gain weight. Then put them in touch with a high-end doctor who can explain to the parents what all needs to be added to their food or to their breast milk. So the second is oxygen monitoring. I think there's no doubt that we must ask what type of oxygenation the baby is getting now. Now, whatever they had, we can't control that. But once they come to us, we need to find out: are they on blenders? Are they on just unmonitored oxygen? Are they on CPAP? And educate the nurse. When you go to the nursery and you see they have put oxygen and the oxygen pulse oximetry showing 100% SpO2, then you need to tell them that please reduce it. So the ideal SpO2 will be 90 to 94 on per pulse oximeter. It also depends on the quality of pulse oximeter. Some pulse oximeters are not sensitive enough to detect small fluctuations. So if they have high-end pulse oximeters, which you will see in high-end nurseries or high-end hospitals, then the babies will not be on uncontrolled oxygen. But in smaller towns and cities where the pulse oximeter quality is not good, may not show true value. So that is why we want that if the baby is on oxygen, then it should show SpO2 only between 90 to 94. So not only that, there should be avoidance fluctuations of SpO2. So for this, we have to educate the nurses and the caregivers. So there are NRP guidelines of how to monitor this oxygen. So again, we need to emphasize on them that please follow the guidelines. You can see here, this is very poor care. Babies will survive, but they will get damage to the rectal vessels because of unmonitored oxygen. So now in some nurseries, there's not enough nurses to monitor, or we see that, there are only few pulse oximeters. Every baby doesn't have pulse oximeter. So at least when you do the rectal examination and you see a zone 1 retina or a more immature retina or a very early ROP, at least tell doctors and nurses, at least monitor this baby more, continuously and make sure that the SpO2 is not fluctuating. What they do is, because sometimes they are scared of oxygen causing damage, they just switch off the oxygen. And baby is okay, like it's 94, 92, then suddenly it will go to 60, they will simulate little, it will come back. When they have to feed, they will that time put little oxygen, other times they will remove. So this is a very bad practice to give intermittent oxygen. So this we should discourage. It has to be a continuous flow of blended oxygen with monitoring and seeing that it doesn't go up and down. And you will find that if you monitor this oxygen well and you can at least take care of that zone 1 retina, the retinas will grow nicely and you will not get APRP or you will not get VCR ROP. They may still get ROP, but it will be very mild. The next is the lung immaturity. So these children, we have to check every visit what is the condition of the breathing. If we see tachypnea or we see babies making some grunting sounds or its nose is blocked, that means it's not getting enough oxygen. So it is under hypoxia. So we have to educate the parents along with talk to doctor that they need to give chest physiotherapy. They need to use nasoclear drops and keep the nose passages very clear and see that baby is having good breathing. If they want or the doctor tells they should encourage nebulization, it will help these lungs to go better. Sometimes they have underlying silent pneumonia. They may need to make parenteral antibiotics. And if there is silent lung disease, it leads to respiratory effort and grunts and lethargy, and also there's slow feeding. So the weight gain is not there. So, so all these things we should check what is the lung status and what is breathing pattern of this baby when they come to us for evaluation. If we see that there's still some cough cold or there's still some breathing effort, make sure that they are on the right path to get it treated. Don't just ignore it. Don't think this is just for the pediatrician to know. So anemia of prematurity is something we are very passionate about. We must treat in maturity. I already showed you one case. So there is no diktat in the literature of how much the hemoglobin should be. But in general, at least have hemoglobin of 16, 17, and then it may come down. But at every 2 to 4 weeks we should check, and you will be surprised that a lot of babies come to us where hemoglobin is 6, 7, 8, 8.5, and the moment you correct that, they start gaining weight, their lungs become better, and their eye also becomes better. Watch the platelets also. So again, literature is there that if they have low platelets, then they can have a problem, and in that case, fresh frozen plasma and vitamin K have to be given. So we should not give unnecessary transfusions because we are transfusing adult blood in a baby, and we give adult hemoglobin, which has less dissociation oxygen dissociation curve, whereas the adult hemoglobin, it releases more oxygen. That's okay, but then anemia is also a problem. So we should follow protocols, but at least while we are managing the ROP, during those 4 to 5 weeks that we want, our treatment or our follow-up and the ROP to go away, at that time we need this hemoglobin at least more than 10. And so we should write to the doctor, talk to them. Some doctors are reluctant to give transfusion because transfusion has its own risk, especially sepsis. So we have to talk to them and insist that, during the phase of ROP management, we don't want any anemia in this baby. And you will find dramatic response to your treatment. So these are studies that we have done in both our studies, and there are other studies also which have shown that we encourage this transfusion, and our outcomes are much better than what are reported in the literature from South Asia. So this is one case which again told us that there are other things beyond hemoglobin. So here, this baby, we were lasering and baby got CRVO. So we have never seen that CRVO developing during laser treatment. And then when we, checked the parameters, we found protein C deficiency. Protein C was very low in this baby. And we found that this happens in sepsis. We were not aware. So if child has repeated sepsis, their protein C can go down, and so they need to get fresh frozen plasma, otherwise they will develop hemorrhages. Sometimes you will see you did laser, you did injection, then suddenly baby comes back with hemorrhage. This is because they have some coagulation problem, especially protein C. So the other one beyond anemia is the asepsis. So sepsis both in around the eyes and systemically. I already said that if baby has systemic sepsis, whether it's pneumonia or blood culture positive, or they have sepsis elsewhere, then they can develop problems. So in the rural setting especially, but also in the urban settings, the insistence on nurses, watch them what they're doing, hand washing, they're doing barrier nursing, they're doing bundle care. Bundle care means that they should not disturb the baby 10 times to do 10 things. They have to plan their workup of the baby if baby needs feeding or diaper change or needs some IV line. So everything should be done as a bundle. It should not be like whole day one nurse is coming, then second nurse is coming, then third nurse is coming, and they don't have a plan for the baby. Because the number of times you touch the baby, a number of times you disturb, it doesn't sleep well, it's getting disturbed. So there are protocols with NNF of bundle care, cannula care. So you can see sometimes we also have to educate them. Any red eye they treat as conjunctivitis, and they just put some antibiotic drops. Whereas if they open the eyes, they could have seen that there is keratitis or endophthalmitis. So every time we have to teach them how to, differentiate a mild conjunctivitis or NLD block from a serious underlying infection. So these things become very important that, the parents and the nursing staff are managing the sepsis. Now, the last but not the least is the mental health. The stressed mothers will not produce good breast milk, and they will not produce milk, so they will affect the breastfeeding, and the baby will not gain weight. These patients who come to us with eye problems, they have high levels of depression, anxiety. Sometimes there are rifts in the family and blame game why this is happening to us. And all this will lead to poor compliance of management, compliance of feeding, and compliance to follow. So you will see that in the clinic, you may be very busy, but there will be some mothers who are very tense or crying. Then give them time, explain to them, give them positivity that things are going to be okay. Talk to your baby, give kangaroo mother care. Tell the baby that doctor, myself, and my whole family and the team are going to make you better, and you're going to be with us. So you can see here how we are, supporting the people. This is Biju Raju giving kangaroo mother care to his son who had very severe ROP many years ago. Here I am with this lady, and this lady, she was so tense, and I'm telling and talking to this baby and indirectly talking to the mother, we are going to make it happen. We ladies are going to make it happen. You're going to be fine. It makes a lot of difference. Parental support group, and we have parents now who have given us permission that they will talk to the other parents when they come in this tense situation in their own language sometimes, or their own religion or their own community, so they can talk to the stressed family. So we should recognize this psychological issue and provide professional help. Sometimes we may have to refer them to a professional psychologist if they're really depressed, because they're going through a very stressful time. And if we give that, you can see her Komal. Don't just examine the eye, talk to the baby, give it support. Don't think baby is not listening or parents are not watching you. They can see your body language. When they see the doctor really caring for the baby, then they think, okay, my baby will be okay because doctor is, talking to the baby nicely. So I think this ROP is a race against time, and we can all get together to take care of this baby. So to conclude, this is just a recap. Maternal health and weight gain, antenatal steroids, perinatal best practices, asepsis and bundle care, postnatal weight gain, oxygen management, lung therapy, anemia, judicious medication, and most important, the psychological support and encouragement at every visit can give us really good outcomes. Thank you.
Thank you, ma'am, for this excellent talk. And it is always it feels so enlightening while listening to your talks. Actually, I mean your enthusiasm for helping the babies with ROP. It's really legendary, we can say. Uh, Actually, we learned a lot from this discussion. Like it's not just screening the eye or doing the laser or giving an injection. It's a holistic approach to maintain for the baby's health as a whole. Uh, right. I would like to ask if Dr. Sabita Devi, ma'am, if you are present here. Okay. Ma'am, anyone from the discussions or any from those who are attending this session, anyone has any question? I think in the chart we have something, but I don't think there is any questions here.
I have a question regarding the oxygen monitoring that you were telling. Any particular form of oxygen therapy, like be it be CPAP or the nasal prongs, like which is more dangerous as compared to the other form?
So I think that, see, we are not the people to dictate to them. They have their NRP guidelines. We should ensure that they have their guidelines. If we see that, they are not sure of their protocols, then we should put them in touch with good neonatologists who can drive that, practice or what is the best. But from our side, if we watch and we see that, they are giving oxygen and they're not giving oxygen, or they are putting it at 100%, then we have to call them and tell them that, look, this is not the practice. You need to improve. So it has to be like a friendly dialogue. It should not seem like we are coming and dictating to them. It is their aspect, but just to bring to their notice and bring to the notice of the parents. If the parents are there and the doctors are not there, suppose they come. Sometimes they come with the oxygen cylinder, or they come in the car, and then I say, "How is the oxygenation?" Then they say, "No, no, doctor told us give oxygen during feeding, and other times don't give." So so these are bad practices. So if we notice some of these practices, we can just have a dialogue with them and then put them in touch with good neonatologists who can guide them more and see what they're doing and how they're doing.
Uh, okay. Ma'am, I had one question regarding anemia of prematurity. Now, if the patient is anemic, then there is the treatment would be blood transfusion. And also, we also know that by transfusing adult blood, that also leads to high risk of development of ROP. So, how do we actually go about it? How do we find a balance between the two, doing transfusion and treating the anemia?
So again, there are guidelines of when to transfuse and when not to transfuse. These are there, the NRP guidelines and the neonatal forum guidelines. So we have asked them that, how do you manage the ROP part? Because in their guidelines, weight gain anemia is there, breathing anemia is there, but they don't have guidelines for ROP. So we have brought to their notice all the literature. So they are not very much aware about the literature on anemia and ROP. So what we have found, and now we have just recently published an article on OCT. Before also we have published, others also have published, that if there's any hematological abnormality like platelets or anemia, then the ROP doesn't go away, because that anemia adds to that problem of the ROP. So what we are telling them is that, at least during the ROP phase, active ROP phase, keep the hemoglobin at least at 10. And why we are saying 10? Ask why 10, why not 11, why not 9? So because of the WHO classification of anemia, where anything less than 10 is moderate and anything less than 7 is severe anemia. So about 10, you can have mild anemia. If it is 10, 10.5, 11, depending on the age of the child and weight of the child. So we are saying at least don't let the baby be in moderate to severe anemia. So mild anemia, we are not saying. So sometimes they will just put on oral iron. Now, oral iron will take a lot of time, but our ROP is worsening week by week. So we cannot wait for that oral iron to help. But suppose baby is like 9.5 or 9.8 and baby is gaining weight and everything else is okay and there's a slow response to your anti-VEGF, okay, we can wait for 1 or 2 weeks and see. Now this hemoglobin also, 1 week it will be 10 or 12 or 14, and then within next 2 or 3 weeks, you will see it has gone down to 8 or 6, because the cycle of RBC is how it is happening. So, every 2 to 4 weeks, we should monitor. And if it is falling, then we should talk to them and say that please give transfusion for that phase of the baby, because anemia at that phase has a problem. But once that phase is over, then it is fine, then they can go. Because why also they are not giving transfusion is, every time you give transfusion, the baby's own ability from the spleen and from the bone marrow to make that blood becomes delayed. So the anemia of prematurity will get prolonged. So we don't want them to just keep on giving blood. But in that phase of ROP, when it is active or we are giving injection, Avastin or whatever we are giving, at that time we don't want any anemia to be present.
Okay. Thank you.
I have a comment here. Can I add something?
Sure. Sure.
This is, I think we all need to put some time on the oxygen, because oxygen is like a, forest fire. So the fire is there, but if you put something that enhances fire, it just burns like anything. So oxygen use is very, very important. I do admit that you will see the babies with severe ROP are the one who were given 100% oxygen. So ideally, to maintain your oxygen level in the body, we don't need 100% oxygen to be supplied. The oxygen need to be blended and mixed with the air before administration. Number one. Number two, when we give the oxygen, there are different ways you can deliver the oxygen. So when you do give the oxygen in the nasal bronchs, you are giving the oxygen directly, and it is closer to the respiratory system. And again, when you use oxygen with a hood, so you need to have a oxygen surrounding environment with high concentration, high pressure, so that it reaches in adequate amount near the nose. So you see that the practice where 100% oxygen is given with the hood and with the prongs, those are the NICUs. You would see that the incidence and severity of ROP high. The second is one should know that the first golden hour. So immediately after birth, when a baby is born, it is normal to have low oxygen concentration. So like they have, there are the guidelines, like up to 1 minute, the oxygen saturation can be as less as 65%. So then another 1 minute, the oxygen still is low, is around 80. After 2 to 3 minutes, oxygen level reaches the normal. So many of us don't know. So in the labor room, what happens in a panic, the duty doctor who is there starts giving 100% oxygen there itself. A preterm baby, when we give 100% oxygen, 6 hours of 100% oxygen is enough to start the process of ROP. So oxygen handling is very, very crucial.
And lung, it also causes lung damage, and then they go into a chronic lung damage phase.
Okay, thank you, sir, and ma'am, for all the informations. Anyone from our discussions have any questions or anything to add this topic, or we'll move to the next speaker? Okay. Then we'll move to our next speaker.
Thank you.
Thank you, ma'am, a lot for this enlightening talk. Dr. Balakrishna Samantray. He will. I invite Dr. Balakrishna to talk on the current classification of ROP. He is currently working as an assistant professor at SCB Medical College, Qatar, and he has received his training in the management of ROP at Elu Prasad Eye Institute, Bhubaneswar, and he is passionate about it. And he has many publications on this subject. Now, I would like to Dr. Balakrishna to kindly start his presentation.
Hello, I'm unable to share my.
Yeah.
Sir,
Subudhi
we can see the screen. You just need to open the PPT.
I think this is the screen of Subudhi sir.
Okay.
No, this is not it. I think he has opened the email from Dr. Subudhi, I think. I don't know.
Okay. So what I am able to see is that you are, yeah.
Now
Can
it's
you
okay.
please share?
Yeah, please share once again.
Now share.
Is it share?
Yes, sir.
Yeah, we are able to see your slides, sir.
Yes. Good evening, all the esteemed faculties. I really feel honored to get this chance to present my topic for you. My topic is current classification of ROP. So International Classification of ROP or ICROP is a consensus statement that creates a standard nomenclature for classification of ROP. It was first published in 1984. It was expanded in 1987 and revisited in 2005. The need for a third revision came into picture in October 2021 because of 3 to 4 main reasons. Certain interpretation in current classification was subjective, number one. Number two, innovations in the wide field digital retinal imaging has put greater insight into the disease. Number three, introduction of anti-VEGF treatment altered the course of the disease like reactivation and regression. And number four, the pattern of disease in certain regions of the world were not adequately described in the current classification. So just to recapitulate our knowledge, the original ICROP had 4 components in terms of location of the disease, like 3 concentric zone, zone 1, 2, and 3. Extent of the disease in terms of 12 clock hours, staging of the disease, stage 1, 2, 3, 4, and plus disease. It was revisited in 2005 and it clarified some concept of more virulent form of aggressive posterior ROP, intermediate form of disease called P plus, and clarification of zone 1. Zone 1 being the posterior most and zone 3 being the anterior most part. This is the in terms of clock hours. We describe it in terms of cumulative and contiguous clock hours. There is before the starting of the stages, it is incomplete vascularization in the different zones, demarcation line, ridge are the stage 2, then fibrovascular proliferation stage 3, and stage 4 A and stage 4B involving the macula and not involving the fovea and involving the fovea respectively. Stage 5 like stage 5A, stage 5B, and total retinal detachment. A plus disease was described as a venous dilatation and arterial tortuosity with tunica vasculosalentis, rigid pupil, and vitreous edge. P plus was not enough to describe as plus, but it was more than the normal vasculature. Aggressive form of posterior ROP, it was later termed as AROP or AROP in recent classification. It is a plus in all quadrants, flat neovascularization, featureless junction, shunting and arcading of the vessel, and rapid progression to retinal detachment if untreated within hours or days. So there are some key changes in the international classification of ROP3, ICROP3. There I will discuss these under these following headings: addition of a posterior zone 2, definition of notch, broader definition of aggressive ROP, definition of PAR, broader definition of plus disease, new subclassification of stage 5, description of reactivation, clarification of regression and long-term sequelae. So coming to the zones, we know the zone 1, 2, and 3. The zone 1 being the most posterior part, zone 2, the middle one, and zone 3 is the most anterior part. And it is classified according to the most posterior location of the disease. They defined a new zone, posterior zone 2 region that begins at the margin between this zone 1 and zone 2 and extends into the zone 2 around 2 disc diameter. A term notch was given to describe an incursion of ROP lesion from one zone to the another, to the more posterior, from more anterior zone to the more posterior zone, around 1 to 2 clock hours in more posterior zone. The ROP in such eyes should be noted by the most posterior zone of the retinal vascularization, like if the lesion is in the staging is in the zone 2 and the incursion or notch is in the zone 1, then it will be termed as a zone 1 secondary to the notch. So plus and pre-plus, like it is dilatation and tortuosity to describe plus disease. Pre-plus, again, abnormal dilatation. It is insufficient for plus, but more than the normal. So it represents a continuous spectrum from normal to pre-plus to plus disease. And these changes should be assessed in the zone 1, in the posterior most part. Stage of acute disease like stage 1, that is demarcation line, which is a flat line, a two-dimensional line. Demarcation line, then stage 2, it is a ridge. It is growing in both width and height. Sometimes there are isolated tops of neovascularization or popcorns. Stage 3, extraretinal neovascular proliferation, and there is a ragged appearance with sometimes the flat appearing extraretinal neovascularization can occur without any stages, that will be termed as stage 3. Aggressive ROP is a term. Previously, it was used as aggressive posterior ROP. Now they have termed it as aggressive ROP or AROP because of increasing recognition that it may occur beyond the posterior retina and in larger preterm infants. It is a rapid development of pathological neovascularization and severe plus disease without progression being passing through the conventional stages. It is characterized by vaso-obliteration, capillary non-perfusions, dilated vascular loops, and AV shuntings, arcadings, plus dilatation and diffuse flat extraretinal neovascularization. Then retinal detachment, stage 4 remaining the same, stage 4A and stage 4B, but stage 5, they subcategorized into 3 types, 5A, 5B, and 5C. 5A being the optic disc visible by ophthalmoscopy, 5B, optic disc not visible due to the retrolental fibrovascular tissue or closed funnel detachment, and 5C, 5B associated with antersegment changes. This is 5A, this is 5B, and 5C, the antersegment changes like antechamber shallowing, central iridocapsular endothelial adhesion, and central corneal opacification. Regression. Now it terms the disease is going away, but it can be spontaneous or it can be in response to treatment. If you are putting anti-VEGF, then it will clear up within 1 to 3 days, or if laser photocoagulation, it will approximately take 7 to 14 days to clear up. But these signs, the signs of regression include the plus component will regress, the vascularization will be to the peripheral avascular retina, the involution of the tunica vasculosa lentis, better pupillary dilatation, greater medial clarity, and resolution of the intraretinal hemorrhages. Now the regression is characterized by thinning and whitening of the neovascular tissue. So the vascularization into the peripheral retina can be complete or incomplete. The incomplete vascularization is termed as persistent avascular retina. This is a term coined by the new classification, PAR. So PAR following anti-VEGF treatment occurs in a greater frequency and involves a larger retinal area. These are the signs of regression of ROP. Now reactivation. Now anti-VEGF have in the introduction of anti-VEGF therapy in the treatment of ROP has created a new situation where the disease regressed but again reactivated. So that may also come after incomplete or complete regression of the original ROP region. It is most commonly, it occurs between 37 to 60 weeks of post-menstrual age. And this may be affected by the choice and dosage of anti-VEGF we are using, and may occur significantly later if re-injections are performed. So then the last but not the least is the long-term sequelae. So patients with can have a premature birth or can have a ROP or, without any ROP may lead to permanent sequelae like retinal detachment, tractional and rhegmatogenous retinoschisis, persistent avascular retina, macular abnormality like smaller foveal avascular zone and blunting or absence of the foveal depression, retinal vascular changes like persistent tortuosity, straightening of the vascular arcade, falciform retinal fold, and abnormal non-dichotomous retinal vessel branching, and even glaucoma. So these are this is the a picture showing the incompletely developed foveal contour and poorly developed FAJ, FAZ, and persistent avascular retina. So these the points have been added in the recent classification. And to conclude, the ICROP3 has put more insight into the diagnosis and management of ROP care and its outcome in treatment. Thank you.
Thank you, Dr. Balakrishna. Actually, it's a detailed and an excellent talk on the current classification of ROP. Actually, I can see some residents here. Do any resident have any questions? Can I know a few of them? Dr. Debasis is here. Dr. Akanksha is here. Do you have any questions regarding the current classification of ROP?
They can also write in the chat box. Like Dr. Chittaranjan is putting a lot of good articles. They can also put their questions in the chat box. So I think there is no question. Everyone has read a lot of about the new classification.
I have one question.
Please, sir.
Dr. Balakrishna, regarding the revascularization, no? You are doing so much of ROP in Cuttack and SCB area in pediatric SNCU. How many you have seen revascularization, the number of cases, number of percentage, can you just tell me?
Revascularization, reactivation.
Reactivation.
Very few cases till now, because the almost greater percentage of cases we do laser. So reactivation after laser is very least. The papers have the incidence is very low, as it is compared with anti-VEGF treatment. The reactivation is more, but mostly we are following the anti-VEGF treatment with laser also. So reactivation chances, I have seen very few cases, or not like that.
That means you say reaction occurs in only anti-VEGF, or so that you cannot know as you are doing both laser and anti-VEGF.
Yeah, the anti-VEGF patients also we are following up after a course of time. We are doing laser to the anti-VEGF previously done anti-VEGF treatment. So the laser is almost a complete treatment. Till now, I have not seen any reactivation.
Thank you. Thank
Sir,
you.
Tapas sir can put some insight into it, sir.
Yeah, so actually, I will disagree a bit. Balakrishna, what you said used to apply well to laser photocoagulation, but in the anti-VEGF era, really the reactivation has been a great issue. So the whether the disease comes back or not depends on many factors. Number one,
reactivation, or is it non-regression following anti-VEGF?
Non-regression. So you mean the question is no response or treatment failure?
No.
So
following anti-VEGF, most of the cases, I mean, you are pointing towards non-regression or non-response to anti-VEGF rather than reactivation. That means reactivation means it has resolved and then it has come back. I think situation is
Yeah.
not like
Yeah, so these terms need to be distinguished. One is reactivation and second is treatment failure or no
yes.
response. So the reactivation rate is very high, there's no doubt. And it depends on many factors like what is the zone of the disease, what is the type of injection you have given, and what is the dose you have given, and what is the systemic status of the subjects. So reactivation can vary from just 10 to 15% in cases of bevacizumab for stage disease to as high as 60 to 70% for zone 1 posterior disease. Reactivation can range from, say, as high as 30 to 40% in cases of ranibizumab compared to bevacizumab. Now, if you take really the cases for no response, so an anti-VEGF when it is given, to find a no response is very, very rare. In fact, I was the current paper which I was working, I've been working is on the no response, and out of the 1400 babies' eyes we have injected, we had only 8 instances where there was no response. That means you have given an injection, there is absolutely no signs of impact of the drug. So this happens, the probable reasons that I found out is number one, the technical issue. Like in an attempt to give very low amount of drug, sometimes the drug doesn't go inside, goes in very minute amount. Number two, technical incorrect way of giving the injections. Sometimes when we give the injections, if you are not careful enough, if you have not gone inside the eye, sometimes the drug can be within the subconjunctival space also. So as if so, what will happen? The baby would have taken the injection, but during the follow-up the next day, ideally the anti-VEGF should show an impact within 24 to 48 hours. So you will see no response at all. Sometimes the disease is so severe, posterior zone half, and when you are giving a drug which is less efficacious or has a less potency, like if you give ranibizumab in very low concentration, that also can show off a no response. But usually, majority of cases, if the anti-VEGF has gone inside the eye, usually you will see some response in the form of reduction in the caliber of the blood vessels, or increase in the media clarity, or in improvement in the pupillary dilation.
Thank you. Thank you, Dr. Tapas. Thank you, sir.
I
So
have
we
just
would
one
like...
more question. Can I just
Yes,
add
ma'am,
up?
please. Yes,
Yeah.
ma'am. Yes, ma'am.
So about reactivation, if you're giving anti-VEGF, so how long should you follow up the baby to look for the reactivation? So it's at the 36
Ideally
to
6
60 weeks.
months. Ideally 6 months. Up to
Okay,
6 months.
Okay.
I
sometimes
would say
it
that
becomes very
Reactivation
difficult.
has been
there are no definite consensus on that. So there are
Yeah.
reports where the disease has come back even at 3 years of age, 5 years of age. And not only for the reactivation, the anti-VEGF treated eyes have this persistent avascular retina. So if you ask me, as long as we have not addressed those peripheral avascular retina, they need follow-up indefinitely.
Is it not better to do lasers if you have
Yes.
avascular retina
Better
after
to
4 weeks
laser
of
those eyes if you
anti-VEGF?
cannot, if the baby cannot come for follow-up, better to laser those eyes.
Not only that, you have avascular retina beyond 40 weeks.
Because,
It is always better to do lasers.
and once the baby gains weight, when his baby is too large, it's very difficult to do laser under topical anesthesia. Okay, so if
Thank you.
everything is okay, then we should do laser.
Yes, sir. Thank you. Thank you, sir. So we will move to the next. So we will move to Dr. Kaushik Tripathi. So Dr. Kaushik Tripathi is a senior consultant at AG Hospital, Kolkata. He is a senior of mine at RP Center AIMS. He is also the editor-in-chief of Stat Pulse Publishing. He is quite active in all the conferences, even for the OSOS. He is always there. So I would like to invite Dr. Kaushik Tripathi, please.
Thanks, Dr.
Yeah,
Kasper.
we can share your screen. Yeah.
Thanks to Odisha Society of Film Society for having me here. So I'll be discussing the risk factors and the role of near-field techniques. So I'll be dividing the talk into risk factors, what are the current guidelines, and what is the role of neonatologist. So most important risk factor is prematurity. It has been shown that both gestational age, birth weight, low birth weight are strongest known risk factors for ROP. And if there is a 100-gram increase in birth weight, it reduces the odds of reaching threshold ROP by 27%. And if gestational age is increasing in a single week increase in gestational age will reduce the odds of threshold ROP by 19%. So oxygen therapy definitely, as Sir said, and Subhadra ma'am also told that high 100% oxygen is definitely a risk factor. Other factors which have been evaluated include duration and prolonged mechanical ventilation puts the patient at high risk. Even if the oxygen saturation is fluctuating, then it can also cause severe ROP. So the target oxygen saturation remains controversial. There have been multiple studies, but there is a need of more data on this. So infant factors in India and Asia, it has been noted, and there have been multiple publications, including by Dr. Anand Pinekar, which have showed, and in our clinical practice also, we have seen that larger and older babies can have ROP in India. So there are differences in different countries also. There have been conflicting results with poor Apgar score and multiple gestation. We have seen that it increases the chances of preterm ROP, but there are other studies also which have shown that it doesn't come true. So there may be multiple other factors which have been involved in those studies. So pulmonary comorbidities, they are mostly well known: apnea of prematurity, respiratory distress syndrome, bronchopulmonary dysplasia, and prolonged mechanical ventilation. So the relation with steroid prophylaxis for respiratory distress is debatable. Hematological comorbidities include anemia, blood transfusion, and administration of erythropoietin. Low platelet count is also associated with severe ROP. So other comorbidities include EDA and its treatments, necrotizing enterocolitis, hyperglycemia, intraventricular hemorrhage, sepsis, poor neonatal weight gain, and slower growth velocity, and longer hospital stay. Perinatal factors, there are conflicting associations with in vitro fertilization, but definitely these also lead to multiple pregnancies, and clinically we have seen that there might be a higher chance with assisted reproductive technology. And it is noted in multiple publications that the areas, the hospitals which have higher level of neonatal care, they have low rates of ROP. And most of these cases of cryo-ROP and ET-ROP, they came from outside, not from the study hospital or trial centers. So there are conflicting results on association with preterm rupture of membrane, and chorioamnionitis or intrauterine inflammation can increase the chances of ROP. So maternal factors, multiple factors have been explored, as Subhadra ma'am told. The status of the mother can affect the chances of ROP. The explored factors include diabetes, hypertension, anemia, age, medication, and smoking, and there have been conflicting results. So we do have guidelines for India. So National Neonatal Forum or NNF of India has given clear guidelines on whom to screen. This has some change, some difference from the American Academy of Ophthalmology or American Academy of Pediatrics guidelines. So we are using this in India. So if a child is born at less than 34 weeks of gestation, or if the gestation is not known, then birth weight below 2000. And if in a larger baby or in an older baby, if they have the risk factors which I have already told, including need of respiratory support, oxygen therapy for more than 6 hours, sepsis, episodes of apnea, blood transfusion, or unstable clinical course, if the pediatrician determines that he needs ROP screening, that has to be done. the first screening of ROP should be performed at 4 weeks of postnatal age. If the child is the gestation is very less, 28 weeks of less with birth weight of less than 1200 gram, then first examination should be done at 2 to 3 weeks postnatal age. So follow-up examinations will depend on the grade of retinopathy of prematurity. And ROP screening can be terminated when there is complete vascularization of retina without any ROP, or if the ROP has shown complete regression. This may take more time also. So how do you anesthetize such patients? We know that severe pain can cause some of these patients to have apnea, which can be a very difficult situation to control and can have medical aspects also. So mostly used anesthetic drops are 0.5% proparacaine and 24% sucrose or 25% dextrose orally in the dose of 0.5 ml per kg just before insertion of eye specula can reduce the pain. And pacifier can be used, and obviously most of the places are using this sucrose to reduce the pain of the baby. So general anesthesia or CT scan and analgesia and paralysis can be used for reduction of pain. Most of the places, practically, we are using administered fluid agents with topical anesthesia and monitoring by the pediatrician or the anesthetist. So what is the role of neonatologist? So most importantly, they should follow the guidelines, and it is known that improved neonatal care reduces the rates of ROP. And they have important role in risk assessment, monitoring. Oxygen management is one of the most important areas. Patients should be referred. Many cases have been referred very late, leading to irreversible outcomes. Pain control during labor, and a multi-collaborative effort should be done between ophthalmologist and a neonatologist and anesthetist. And patient education support are vital to reduce chances of ROP, and also the parents should know what is happening to their baby. So my take-home point message will be: patient's systemic conditions should be optimized, neonatal care should be improved, patients should be screened timely, and they should be referred timely. That is very important. And once stage 5 ROP happens or things go beyond our control, then it is very difficult to get an optimal outcome. Thank you.
Thank you. Thank you, Dr. Kaushik. Thank you for the talk. I would request Dr. Manmohan sir. Sir, what is your take on the ROP babies or the premature babies who are also having cardiac diseases like the PDA, ASD, or the large VSD? Do you find because you are working in a setup that can cater the needs of these babies, do you find that these babies are at a much higher risk of developing ROP?
I don't know. I'm not aware of such associations.
Because I was thinking because the neonatal, because all these conditions, be it PDA or the ASDs or the like, because they can cause also the hypoxemias. So I was just thinking whether they can further aggravate ROP. Maybe Tapas sir can have a point here.
They could,
Yeah.
because they affect the feeding. They affect the feeding, they affect the respiratory rate. So the weight gain could be lower. We know that if patient has cardiac disease babies, they will have lower weight gain. And as you rightly said, they could also have problem because of the problem in feeding. They could have less of anemia or less of other proteins. And actually our basic science testing has shown that these for surgery, they have a very abnormal fatty acid metabolism and fatty acid components in their vitreous and also in their blood. So so while we are talking about anemia and all, we have not explored many other factors. Our data a study of the vitreous we have published that also showed that there are a lot of inflammatory mediators. And actually, when you're doing ROP skinning, you can actually see that vitreous haze. It's almost so cellular, that vitreous, that there is a lot of vitreous haze. So vitreous haze is known to be a component of plus disease. But why is that vitreous haze there? Actually, our study shows there are a lot of inflammatory mediators up regulated in these eyes. So there would be other things which are happening. So I think you're right, although I'll have to go and see and there or not. But indirectly, it would influence the ROP because they would have poor weight gain.
Thank you. Thank you. So I would request Dr. Bhutendra to kindly introduce our next speaker, please.
Thank you. So our next speaker is Dr. Bhavik Panchal. He is currently working as the head of L.U. Prasad Eye Institute, Visakhapatnam. His area of interest is pediatric retina and retinopathy of prematurity, and his recent works include the management of ROP in babies with oculocutaneous albinism and bleb-like ROP, all these complicated ROP cases. But unfortunately, because of his some personal work, he is not live now, but he has recorded his all his talk and send it. So I'll play it now. Now how do I'll
I think this is going to be a very awaited talk. Like everyone want to know how to treat a case of ROP. Yeah, we can see your screen, Dr. Bhutendu. It's great that Dr. Bhavik is also connected.
It's audible also?
No, we are not able to hear you.
Just 1 second. The audio is not. You can hear anything.
We are not able to hear the audio. And you can just play. I think it's not starting play. You can play the video.
Okay, I'm just playing.
Not started, I think. Yes.
Just 1 second. So but this thing is not audible, right?
No, we cannot hear. Very
Okay, that
faintly
I'll
we can.
yeah, but that I will play. I'll just once. One second. That I'll play.
Okay, you answer and come again.
Good evening, everyone. No, it will come.
When you look at this image, what do we understand? Temperature.
I will just synchronize both.
What about
Just
eyesight?
give me 1 second.
This is what we are going to understand today. What happens to the children who are diagnosed with retinopathy of prematurity? So, welcome to today's talk on treatment of ROP.
This is audible, right?
So,
Yes,
retinopathy of prematurity, why make a noise? Because there is no disease at birth. India has the highest number of preterm births, that is 3.5 million in 2010. And up to 18,000 infants will go blind every year in India until it's scaled up. So, what do we understand from this graph here? Right? The infant mortality rate is falling compared to what we had seen earlier, right? But blindness from ROP is increasing. This is how a normal retina of a neonate or a preterm child looks like. And this is how a child with retinopathy of prematurity appears. This is an aggressive form of retinopathy of prematurity. So let's come to a topic, that is, what are the treatment modalities in ROP? The first and foremost and the traditional treatment modality, which is still being used, is laser photocoagulation. The aim of laser photocoagulation is to ablate the entire avascular retina as rapidly and as completely as possible with minimum side effects. If you look at the pre-procedure preparation, few blood investigations are required, like a hemoglobin platelet count, Ideally, the laser should be done under general anesthesia, under an neonatologist care or anesthesiologist care. Explain the parents' need for follow-up. The child must be fed in burp 36 to 60 minutes before the treatment if topical anesthesia is used. And the baby should have warm clothing and diapers to avoid hypothermia. The materials which are required for laser is a sterile periodic eye speculum with a wire vectors. Yes, of course, dilating eye drops and topical anesthetic eye drops are required along with the sterile wrinkle lactate in a syringe. Yes, laser with the indirect ophthalmoscope. And suction apparatus and resuscitation and intubation equipment should be handy. So pupils are dilated, autoclaved or chemically sterilized instruments are used. Please follow the NICU protocols whenever you visit an NICU. Radiant warmer is required and keep the AC off. Hypothermia is more damaging to the child, right? And always the child should be connected to the pulse oximeter. A diode red laser is preferable. However, NDAG laser can also be used. Start with a lower energy and then titrate the burn accordingly. Because in the peripheral retina, the retina is thin, a vascular retina. With lower energy itself, you may get a much better and a higher, brighter burn as well. If the intensity is too high, it may cause a retinal break. See, the intensity must be grayish white and the placement of spots must be nearly confluent. We understand that, and remember, anterior retina requires lesser power compared to the posterior retina. So treat the entire avascular retina, the ridge or the vascular part of the retina up to the ora 360 degrees. Treat up to the base and all around the ridge, and do not leave any untreated skip areas. The skip areas themselves can be a further nidus or place where a new vascularization or recurrence may occur. 1,000 to 2,000 spots are more or less enough in one sitting, and if it's an aggressive ROP, around 3,000 to 4,000 spots are adequate. What not to do? This is extremely important. Do not depress the globe very hard and release the pressure on the globe suddenly. Heavy confluence spots anterior to the point of entry of the long push ciliary vessels and nerves can lead to pain and damage. Burns of the ciliary body are complete no-no. And do not use a depressor beyond 3 to 4 mm beyond the limbus. The complications associated with laser photocoagulation are corneal opacity, hyphema, iris atrophy, ectrophy nevi, cataract, vitreous hemorrhage, exudate retinal detachment, hypothermia, and so on. So this was about laser. Coming to the most widely used treatment modality at this present day and age is anti-VEGF therapy. So if you look at the indications of anti-VEGF therapy are aggressive ROP, zone 1 any stage with plus, zone 1 stage 3 without plus, zone 2 stage 2 with plus. So much of the lower zones you tend to treat with anti-VEGF. Presence of neovascularization of the iris, sick babies who cannot undergo laser, right? Salvage therapy after failure in laser, before surgical intervention for stage 4 or 5 ROP. What technique we follow is a safer protocol, that is using a short needle, use of antiseptic antibiotic, that is fluid and iodine, that is used most commonly, proper follow-up post-injection, right? Extra attention to detail like maintaining clean environment, use of sterile gloves, assess for conjunctivitis, nasal duct obstruction prior to injection, determination of safe injection site around 0.75 to 1 mm posterior limbus, right? This is extremely important. And finally, recheck. The recheck 1 to 2 weeks following injection. So there's a protocol of follow-up as well until the mature vascularization of the retina is complete. Right? You can use fluorescent angiogram SOS when required. So the question arises, what is the preferred dose of anti-VEGF injection ROP? The various studies which have used multiple doses. However, the most convenient dose which is used by everyone is half the adult dose of anti-VEGF. When you look at the comparison of various anti-VEGFs in ROP, ranibizumab has the highest rate of recurrence, as high as 48.1%, whereas aflibercept has a limited number of studies which are there, the lowest recurrence rate. Recurrence time after initial treatment also is the lowest for ranibizumab compared to the other two drugs. and the age of recurrence as well. So the recurrence comes much earlier and much faster with ranibizumab. So anti-VEGF treatment is here to stay. Advantages are ease of use, rapid response, lesser myopia, better visual fields. Caution is delayed vascularization, recurrence, and challenging follow-up. If you look at the signs of regression of ROP, both treated with laser or injection, what happens is the media clarity improves, pupil dilates fully, there are no new vessels in the iris, all retinal, parietal, and vitreous hemorrhage are cleared. Regression of dilatation and tortuosity of the retinal vessels, which will happen as time progresses. No new vessels, no increase in retinal traction, no elevation, no elevated ridge or posterior to the laser mark. This is one such example who I had lasered in the year 2017, where anti-VEGF was not much widely used. Right? This was treated for an aggressive ROP. And now this is the outcome of a child treated with anti-VEGF for aggressive ROP. Correct. So you can choose your treatment accordingly. Just a few slides on novel potential biomarkers for ROP. Various biomarkers have been studied, metabolites, gut microbiota, cytokines, oxidative stress biomarkers, and so on. So these biomarkers basically help us provide a direction that beyond treatment, can we prevent the formation of ROP itself? That is what is the aim of studying these biomarkers. Nowadays, everywhere is AI, so no talk can be complete without we speak about artificial intelligence and ROP. Various studies have already performed with various protocols and algorithms, both deep learning as well as LLMs. So there are several sites or several prediction models also are available on the internet for detection of ROP. And my presentation would not be complete if I don't thank these two individuals, Dr. Subhadra Jalali and Dr. Tapas, both are present here. Thank you so much for teaching me everything in retinopathy of prematurity. Thank you so much. You can reach out to me. This is my email.
Thank you, Dr. Bhavik. I think it was a great presentation. So I will just request Pramod Sharma sir. Sir, what is your take on bevacizumab versus ranibizumab, like the efficacy versus safety? What way do you go first?
Actually, we are the government is supplying ranibizumab, so we are giving here in our setup. But being the molecule is larger, bevacizumab, so retention is longer and the outcome is good. But due to the constraint, we are working in a public hospital, so we are, though recurrence rate is high in ranibizumab, according to the literature, we are sticking on that. And sometimes, if just like persistent avascular retina, we are not taking any risks. At that point, we are applying laser to that area.
So, sir, are you using a single vial of ranibizumab, like you are dividing it into two and then giving in both the eyes, or you are using vials?
No. It is that ranibizumab is supplied by the government. We are dividing that in two eyes.
Sir, because
I would request Dr. Suchitra Panirayan, if you have any question, you can ask.
Hello.
Okay. So, Dr. Manmat, sir, do you have any question, or like, what is your take on like going ahead with aflibercept? Have you ever given aflibercept for injections?
No, I have never used except bevacizumab. I have never used anything.
Yeah. That is like for me also. Maybe the Avastin is the first injection that to go ahead.
Long-term studies have shown that Avastin, those injected versus laser versus Avastin, they do have normal antechamber depth and no refractive error versus those those who have underwent laser. So, but laser is here to stay, especially in India, because which needs long-term follow-up. So if a baby cannot come for long-term follow-up, the better to get the laser done.
One more question to the house. Does anyone treat pre-plus stage of ROP? It is not plus, pre-plus stage.
No.
Yes, I think I have a doubt.
Yeah, please, ma'am.
Hello.
Yeah, please, ma'am. Ask your question.
Actually, all the medical colleges, they are supplied with biosimilar ranibizumabs. So, can it be given to the babies or not? Mostly in medical colleges, these are the biosimilars, not the ranibizumab.
So
Yes.
if I can answer this,
Yes,
so
Tapas sir,
first,
please.
before this, I share my take on the anti-VEGFs. So among all the anti-VEGFs for ROP, not for other diseases, bevacizumab is the best, even compared to both aflibercept as well as the ranibizumab. Studies have shown. Now, ranibizumab, definitely the potency is less, the therapeutic effect is less, and the recurrence rate is high and earlier. Like if you are giving ranibizumab, be prepared that the disease can come back early and more frequently than what we are giving the bevacizumab. Regarding biosimilar, there are many biosimilars that have come up, but the one Rajumab that is from Intas has been approved, so this can be used. The other agents before we use, they need to do the phase 4 trial. Phase 3 and 4 trials to prove their efficacy before we are legally correct in giving those injections.
Thank you.
Thank you. Thank you, sir.
One
So
more
I think we shall move on to like any more questions, ma'am? Do you want to
Yes,
ask more questions?
actually in MKCG, if we give it to the zone 2, stage 2 and pre-plus, actually by giving this babies had more problem for me actually. Zone 2, stage 2, pre-plus. If you give
Yeah, so while it is good that many of us are giving injections, but injection is not just giving the injection alone. There are many things associated with it. The proper selection of the cases, whether the baby is eligible for injection or not, how to follow them off, whether we are giving technically correct or not, and are you able to pick up, are you well acquainted with the signs of regression, signs of reactivation, are you ready to follow them up? If we don't do many times, once a while, it can be counterproductive. So for like cases like zone 2, stage 2, pre-plus, there is no need for intravitreal injections. Even the treatment also, indications for treatment also doesn't indicate that the disease can be treated in this stage, unless there are very rare instances where no other eye has already been affected, or you suspect that baby is never going to come back to you.
Thank you, sir.
So there are
This one
guidelines.
point I want to make.
Yes, ma'am.
Shashwat,
Yes,
this
ma'am.
is regarding the legal aspect of using any drug. Okay, so there is no problem in that. Every day for end of we are using illegal drugs like vancomycin, ceftazidime. Every day for cataract surgery we are using ringer lactate. None of this has been approved for ocular use. Okay, so there is no issue. It only is important to take the informed written consent, that you are taking the proper consent, you are informing the patient that this is off-label. See, now this off-label has come because the companies are making it legal, illegal. Okay, but nobody is making legal, illegal for vancomycin. But after ringer lactate, if you get and companies don't take onus, they fight in the court and say we have not made it for ocular use. The ophthalmologists are using, we have not told to make. I mean, the ringer lactate is contaminated. They are not talking about that. They don't take that ownership. They say it was not for ocular use, so we are not use it for ocular use. Why did they use it at all? So they will do that. So I think it is important to take the proper written informed consent and have a discussion with the family. See, the litigation and all thing comes when our communication with family. Then even for legal drugs, they can sue you. Okay, so they have to find. But if our communication is nice and we are good to the patient and we are taking care, and if somebody is trying to make mischief, we immediately curb that at the first sight and have a dialogue with the person creating mischief, the chance that litigation will happen is very rare. Even if it happens, you have enough data to say that worldwide people are using. There are so many publications, you can take that out. So you should be involved with answering the queries. There is no issue about that. Day in and day out, off-label drugs are being used here. As long as the drug is approved for human use. Okay, then we can't use crocin for pain. We have to use it for fever because it is approved only for fever. Then you are using illegal crocin. Okay, so you are using illegal vancomycin in the eye. So don't worry about that. Understand the issue and have good counsel. That is very important.
Thank you so much, ma'am. Thank you. So, moving to the last talk of the day and the most anticipated one. So, Dr. Tapas Anjan Padi needs no introduction. Both Subhadra ma'am and Tapas sir are like Lord Krishna. They are all guiding us all along the darkness of ROP and pediatric retina. So, I would request Tapas sir to kindly share his screen and present his talk on his experience of managing ROP in Odisha. Over to Tapas sir, please.
Yeah, very good evening. Just give me a moment to share
Sure.
my slides. Let me see. Are my slides visible and is it in slideshow mode?
Yeah, sir. No, sir. So it's not in the slideshow mode because now it's in the slideshow mode.
Okay. Thank you so much. And thanks to the society for selecting this topic, which is often ignored, and also all the participants and the speakers so far for the for enlightening us on ROP. Now, before we go, before I share the management in my experience on retinopathy of prematurity, we should know that what is the ROP burden in the state of Odisha. So these publications by us, along with Claire Gilbert, showed that out of every 100 babies at risk of ROP, the risk of ROP, we heard that 1, 2, 3, 4, like babies born with gestational age less than 34 week and or birth weight less than 2 kg are at risk of ROP. So if you take those babies out of every 100 in Odisha, the incidence of ROP is about 35 to 40. And among them, the babies that require treatment is around 8 to 10. So in Odisha, if you take both government neonatal care units as well as private units, roughly 60 to 70 babies are at risk of blindness if the ROP screening and care is stopped. So this 60 to 70 per month is not a small number for a disease that can be completely cured. So there is a very high need that we should touch this population and do the steps to prevent this curable disease. We did a study thinking that we introspected why are we facing with so much of stage 5 ROPs. What could be the probable reason? Unless we know the reasons, the disease burden is going to trouble us more and more. This study showed that you can see that this green portion area, there is this area, there are no screening facility at all. No awareness on the screening, no screening facilities. Then you have areas where there is failure to provide ROP care, parental neglect. So the parental neglect is only up to this. So these factors up to this, you can say that 70-80% of these factors can be corrected. And both ophthalmologists, pediatricians, the general public, the government, all of us are responsible, and we need to work in unison. You have to win over these diseases. And over last 12 to 13 years, you can see that we were able to screen 24,923 babies with 9,371 babies ROP of certain degrees and 1,843 babies treated. In our universal eye screening study, we showed that each baby going blind is equivalent to 50 lakh loss to the society. So you can imagine that 1,843 babies treated or saved from the blindness should be about 900 crores saved from the society. So any amount of investment that we are doing to save these babies, leave alone other benefits, which are more important actually. Money wise also, the return is many fold higher than that we invest. This is the model that we started initially. We realized that if you rely on the babies to get referred and come to you, then I am sure that in the region where we are working, 30 to 40% of babies are not going to come back to us. So wherever we are screening, whoever is screening, in addition to catching the babies at the institute, we need to go to the NICU and serve them there itself. If we don't catch them there, then there will be a loss. That's what we realized initially, and created a mobile team where the doctor and the photographer and the technician visited the peripheral units. But the numbers to treat were way higher than the capacity available. So as a result, the next phase was the tele-screening. We took the help of the tele-screening, where the mobile team, you can see it's a trained technician who goes to the periphery, takes the images and shares the stores and forwards it. You can access it over your phone or laptop, and after that a decision is taken whether the baby required treatment or not. Depending upon the systemic status of the baby can be either treated bedside or can be brought to the main center where you can treat them. So this has been there for quite a long period of time, but there are lacunae in this too. Like the process is more or less a technician driven. Like there is no face-to-face talk, face-to-face interaction with the parent and the doctor. One may have a phone call, but the parents and the care provider think that probably this is a technician driven, and you won't have any choice to, in case you want to re-image the baby immediately or refocus a certain area, then there is no such, you have to call the baby again. So what we did, we modified the process into the real-time ROP tele-screening, which I am going to discuss in the subsequent slides. Now we learned from Bhavik that the disease has a very good and predictable outcome after laser, and you can see here the extraretinal fibrovascular proliferation regresses after laser. But if you delay the treatment, it can lead to the blindness stage 4, stage 5 that can present with a white cornea, and many times it gets misdiagnosed as corneal opacity or cataract. So any case of any baby with corneal opacity or cataract, it's very crucial to look these babies under microscope. You will see shallow AC and the lens and iris touching the cornea, and it's important to take a detailed history on the prematurity because the management differs. This is the trend of ROP that we saw, the number of babies to be treated versus those treated. You can see that the number in yellow, they keeps on rising, and at present roughly 600 to 700 babies we screen, and the approximately 1/3 of them have ROP, and again 1/10 require treatment. The numbers are rising again. We discussed that the oxygen plays a crucial role, and many of our NICUs that we have, we use 100% oxygen. So there is no blender available, no monitoring available, one monitor for many beds. So these have become factories for aggressive retinopathy of prematurity. We all need to get ourselves acquainted with this disease, because this disease where if we don't act fast, then it can cause very quick and irreversible blindness. As you can see here, this is a half zone ROP. Half zone in the sense the most blood vessels are behind the foveal center, and this in addition to the multiple arcading and shunting that is there. You can see that we gave intravitreal injections, and post intravitreal injection the disease regressed, and after that the parents were lost to follow up and came back after 1.5 years. And when they came back in 1.5 years, the changes were very subtle. We couldn't find out. There were suspicious of few early neovascular activity, but we are not sure. And on angiogram, you can see that the profuse leak from the new blood vessels at the angio done under general anesthesia, and at the vascular and avascular junction, and followed by the laser was done immediately, and we avoided a reactivation induced further aggravation of the disease by doing laser in time. So this is what is our publication. We had two publications, one in the eye and other one is the retina, on the zone 1 posterior retinopathy of prematurity. Now, compared to the aggressive ROP in the zone 1, the posterior zone 1 ROP differ in many ways, with very poor outcome, higher recurrence with anti-VEGFs, and it needs a special strategy. And this strategy included a 7S algorithm for posterior zone 1 aggressive retinopathy of prematurity. The screen early, day 20. In fact, the features of ROP start as early as 10 to 12 days of life in these cases, but they're very subtle. If you catch them early, run with them, and you have an opportunity to modify the systemic course of the disease, so that many of these eyes might not go into the aggressive retinopathy of prematurity. Half the way they can get converted to staged ROP and regress. Additionally, you have an opportunity, the moment the eye worsens, you can treat them. Second, safe use of oxygen that we discussed. Systemic corrections, very crucial, very, very crucial. The ROP is a ophthalmic manifestation of a systemic disease. We all know that how good quality newborn care can reduce the incidence and severity, and that we have witnessed in many NICUs in the Cuttack and Bhubaneswar. Stress and weight gain, the next to the prematurity, low birth weight, oxygen, the weight gain, the better the weight gain, the lesser the severity of the disease, higher the chance of recovery and response to the treatment. And for half zone ROP, it is mostly the strategy that shows best outcome. To our experience is start with intravitreal anti-VEGF if there is no contraindication like traction, and supplement with laser by default. So staged ROP in other areas, one might observe them if the babies are coming well, baby is recovering, and the vascularization is progressing well. But in this zone, I usually tell go and treat them with the laser by default. Now, finally, a search for atypical characteristics. There are many atypical characteristics that as well. Here, the stage 4. Now, once we know that the up to now the disease, if you do laser in right time, one can have a very good success rate, more than 95% of success rate. But sometimes even the disease in the stage 4A, we still have an opportunity, as you can see here, with timely surgical interventions, lens sparing vitrectomy, the outcome can be excellent. Sometimes when it progresses further, or atypical cases or stage 5 cases, the outcome becomes devastating, but not zero. So the point here is that I don't say that that we are able to operate stage 5 ROP with some hope. It doesn't mean that we let our babies at any cost reach this stage. We always should put our effort that you intervene much before them. But the slide here shows us that if you have stage 5 ROP, you have not lost the game entirely, and surgeries can give some amount of ambulatory vision to these individuals, as you can see here. And the detached retina is not a dead retina. I will again go back to the modified strategy. Now at present we are adopting this called as real-time ROP telescreening, where we have incorporated the video conferencing in addition to the telescreening process, where the remote reader video conferences and witnesses the screening activity going there. And there with many advantages like this, and one can have a control unit here, and multiple units there, where you can have 2 to 3 mobile teams with a technician and a photographer who can go there, takes the images and share the images with you, and like in a control room the images can be analyzed. This is a short video, 1-minute video, that shows the impact of the real-time ROP telescreening, and this showcases a particular segment of our work in collaboration with Cognizant Foundation.
Thank you so much, Dr. Tapas. Sir, like this is a slogan that we have learned as we were learning ROP in Roshni Ke. I was with ma'am for 2 years. So we have all known this Teest in Roshni Ke is very important slogan that we should all learn.
Is the video visible to you all?
Yes.
Yes. The video is moving on. Yes, sir.
Yes, so it's a collaboration with Cognizant Foundation, and this is a 1-year data where the real-time ROP telescreening process, we raised awareness, and the team goes to the periphery. You can see the images being taken. Remote rural area babies are also we are able to catch them. The reader here counsels in real time with the patients at the remote periphery. And this segment of the project saw the babies and saved around 216 babies with many smiles, and saved the babies that would have otherwise gone blind. So I stop here, and this is the training. While the screening goes on, it is very important to build up the training, the capacity for the independent ROP care. Our motto is that once we reach all while we put our endeavor to touch upon all the districts where there are no ROP services, it is important also to build up the capacity for ROP screening and treatment, so that slowly we phase out and hand it over to the government and create a system where the legacy continues. And I am thankful to all of them, including Dr. Balakrishna, then Sasmita, and Dr. Sabita Devi. So more around many ophthalmologists across the state who have come, got trained, and they are continuing to provide service. Samir here, and they're providing service to the periphery. I am thankful to all of you, and I wish you all should continue the ROP care and build your capacity to next higher level, that is treatment of the babies with laser as well as intravitreal injections. So this showcases the system, that process we have created. While a word of caution here, we are dealing the babies who are very sick and fragile. While we have a good intention to save the eye, at the same time we can't ignore the life also. These babies, anything can happen at any time. You need to create a system where you deliver care on the priority basis throughout, from check-in to check-out, as Madam said, Doctor, so nicely, that one need to be very much vigilant on the baby and should check them out as quickly as possible, and always should have a backup available, like a neonatal nurse here. These are the warmers and a pediatric anesthetist available, and basic life care support for a neonate should be available to you, and we all should be acquainted with those basic life-saving procedures if we are doing ROP. That's very, very crucial. So it's a teamwork, and the team, I'm thankful to the team with me, and I hope, no, you see, look at the mother and the second mother with the baby, they're such a fighter, from such a long distance that they come to the for the care, and it is our duty, our responsibility. We are their guardian to make sure that I tell that, no, we should put all our effort, not only deliver care, cure the baby, but send the baby safely. That's very crucial. And these are few other examples how these babies are being served. And our aim is that there is a need not only to expand by 2030, but at the same time the process is to be strengthened. Now, like we are many people, they start injecting, and post injection we are not following them up, then it is of no use. So it's very important that once those babies whom we have screened, whom we have treated, we also follow them up, so that the process becomes very, very, very efficient. And that's what we are going to address in our future year. And it can't be feasible without you all, your support, your contribution, and your dedication and commitment. Let us make our state free of this curable blindness. So I thank you, thank you all and the society for giving me an opportunity to share my thoughts on it.
Thank you, sir. Thank you, and heads up to Tapas sir for doing such a pioneering work in ROP in our state. Sir, I would just like to ask Sasmita ma'am, Dr. Sasmita Sahu is here. She is doing, I think she is the one who is seeing a lot of ROP babies, premature babies in Western Odisha. So ma'am, how do you see the ROP care in Western Odisha? We have Dr. Sasmita Sahu, please.
Dr. Tapas, please stop share. Yeah, thank you so much.
I think Dr. Abhimanyu Acharya sir, sir, are you there? So, any discussant, any panelists they would like to add the difficulties that they faced in ROP treatment screening in the state of Odisha, they can put forward their thoughts also. Then we would move ahead with Sylvester ma'am for the end of the session.
So we are doing a lot of cases, doing lot of screening, but we are facing difficulties in management. Hello?
Yes, ma'am. Yes, ma'am. You are audible, ma'am.
So we are doing a lot of cases screening, but we are facing difficulties in management of the advanced cases because the babies are very much premature and they have very unstable their neonatal course. So it is very much difficult to ship the baby to higher center like your BPSR. So we need here this management should be available here.
So I request the volunteers.
Especially leisure, because we are giving anti-BGM and the recurrence rate is very much high in ranibizumab, and especially in zone 1, disease in zone 1, but zone 2 patients, they are doing well. The recurrence rate is very much less as compared to the zone 1 disease. But for leisure, we are facing difficulties because we are not well versed with the procedure.
Madam, you
So
can
I
send those babies to Shashwat and Sitaranjan. I think they are in Sambalpur working.
And these
Anyone who has
babies,
helped.
they cannot afford the this cost.
No, the
so
RPSK.
I volunteer.
RPSK people are not there. There is no help desk in BSS. There is no RPSK is functioning.
No,
They
can
are
I?
functioning at Sambalpur. They are functioning at Sambalpur, not at BSS, Bhimsa.
In pediatric
I
department, the
I
RPSK people are there.
I request volunteers, whoever wants to get trained in ROP. So I am ready to assist him. So in try to make him, independent in the ROP care, but it needs some time. So though it's depending upon your pre-exposure to the indirect ophthalmoscopy or laser, the time can range for 1 month to 2 months to 3 months. So anyone who wants to get himself um, built up the capacity for laser, I'm ready to assist.
I'm
Sir,
also
thank
requesting
you.
everybody. I also request everybody, and I've been saying this for many years. If any of you are doing laser treatment, please train one more person along with you. You are putting 1,000, 2,000, 5,000 spots. Train one more person along with you. One person, tapas cannot train all the world. I cannot train all the world. So those who have already got trained and are already doing the lasers, please get one more person and train them. Every time I'm training two people, one on one eye of the baby, start giving them nasal side laser. So our doctors are so good. They are just waiting for an opportunity. So there's no point in you yourself doing 5,000, 6,000 spots in a baby. Get somebody to start, help them to start, teach them. Then we have so much strengthening of our ROP work, rather than thinking that Tapas is going to train the whole world or I am going to train the whole world. It's very difficult. But opportunity is there. The babies are there. We are treating. Just train your doctors, train your friends, train your fellow students to start doing this work. Then we can polish. So in Bangladesh, I trained one doctor. Then I got 20 requests. I cannot train 20 Bangladesh doctors. So I told them, you get trained from the person I have trained. Then for polishing, you can come to me for a week. Otherwise, it will take 16 years to train 16 people. So please, that's a deep request. Everybody has learned. Train the next.
Ma'am, a point of note here that we have many people here who can do very good laser and train also. It starts with Dr. Santosh, Manmat, Sangamitra, Chitta, so Balakrishna also, and
Shashwat, yeah?
Aparajita.
Everybody, please train
So one need to keep on practicing it. And
देखो फिर मैं जाके सोती हूँ तापस शाश्वत ये सब लेजर करते हैं मैं जाके सोती हूँ डांस करती हूँ
Actually,
want good life तो औरों को ट्रेन करो
ma'am, actually in Odisha, I think after LV Prasad, JPM Rotary Dr. Santosh is training. So here I'd like to, I think we can write a letter to our state society that others big center can be asked for to train, because I think Tapasar, what you told, that 2 out of 30 districts, and I don't know what about the other districts. Is it the government or the private institute, anyone? And we can write.
No, the training program is already running. Along with it, they go both to the Rotary as well as LV Prasad. Recently, for last few months, it has stopped, and I am in negotiation with them. It is going to restart again.
Yes, this is just
And all
stop
of
for
us.
this month, Tapas.
Yeah, that's the only
Yeah.
institute, Santosh.
I just want just one line that it not only the centers, but also it needs a passion to do lasers in ROP, because unlike anti-VEGF, it does not complete in 1 minute, and also it's not provided by government. So you need to develop a passion and you need to spend time for those babies.
And you need to have good heart.
Yes, you need to have.
Yeah, again, I re-echo what I was taught by Subhadra ma'am, that it needs, for laser, it needs hand, head, hours, and heart.
Yes.
Yes.
So,
Without
Fully
that,
agree.
cannot
Fully
go
agree.
for laser. That's the truth. I've seen you doing laser. I've seen Santosh even. So here I have to request, even you can write a letter to our secretary that you open 1 or 2 more centers, because I think government people they've started doing. I remember you are my guru in ROP 7 to 8 years back, and more private institutions has to come up for this ROP. And Savita, Balakrishna, and Pramod, and I think all they are doing a good job in the government setup. Thank you once again. So,
Sir, one practical problem I'll tell, working in a tier 2 city of Odisha, especially the peripheral parts, in addition to all the technical things and expertise of ROP that has been discussed, the absence or difficulty in availability of anesthesia, the RBSKY and other affordability, those are second, third, and fourth that will come. The availability of step backward while kind of doing laser or injection or anything. As by all the speakers, it has been told that we should have a good neonatal rescue team available with us. So, any points how we can help in that? How we can help the babies with regards to the absence of or unavailability of anesthesia doctors with us while managing these babies?
Chita, in that case, actually, what I was doing while I was doing, while I was working in a standalone eye hospital, so you have to do laser under a anesthetic backup. So yes, they should have the minimum ambu bag and basic resuscitation equipments. And if anything, the baby develops apnea, then the anesthetist can take over with continuous monitoring of saturation and vitals monitoring. So if during laser, let's say, and particularly scleral depression that causes apnea. So then the anesthetist then warn you that you just stop laser and let the baby breathe for then you can start laser. So it is always good practice to have a anesthesia standby.
If you don't have
If you are doing laser in NICU, it's no problem. But if you are working in a standalone hospital,
it's difficult to get answer in the doctor, like in the hospital also. That is the problem. Maybe Subhadra madam is telling something. You should listen.
Yeah, do it in the NICU itself. All the pediatricians, nurses, everybody's there. Do under their monitoring. They are used to intubating babies in the NICU itself.
Yeah.
So if it is a remote SCNU where they are not intubating, shift it to a government SCNU in the city. And for many years, I did not do any lasers in LV Prasad because I did not have the team there. Even if baby came from outside, I would tell it, go and get admitted in a hospital, I'll come and do there. So I never did it in my hospital because for small babies, we had no backup. Now we are able to do. Still, if the baby is sick, I don't do it in my hospital. I get them admitted in their pediatric hospital, and then I go and do it there.
Okay, ma'am. That's a good tips actually. But if the baby is also discharged, we will ask him to get readmitted again there in the NICU.
Yes, at least for daycare. Then at least they will handle. They will put IV line. They will have all the ambu bag, the tubes. Their staff is there. Their residents are there. They can monitor and they can help to resuscitate. You know, if something happens in our eye hospital, we can't arrange that. It's very difficult. Now we are able to arrange because we have a lot of load. But for a normal eye hospital, it is not possible to have all that thing there. So best is to send to the local center and then go and do it there. It's little effort. You have to find time, maybe at the end of your OPD or some other time or evening or Sunday. But better to get it done in the hospital where all the facilities are available.
Okay, ma'am. Thank you, ma'am. Thank you.
Thank you. Thank you. Thank you, Dr. Subhadra. Thank you, ma'am. I would like to hand over to Dr. Sarmishta, ma'am, over to you. Thank you, Dr. Bhutendu, for helping us together to guide around the show. Over to Sarmishta, ma'am.
Thank you a lot, and same to you also.
Thanks, Dr. Bhutendu and Dr. Sashwat for a very great moderation. Dr. Samir, would you like to give the vote of thanks or should I go for?
Ma'am, I'm just here. I'd like to thank Chief Guest Subhudi sir and who's here. I would like to thank Subhadra, who is really enlightened us regarding what is ROP and what we are doing, like taking the example of protein C and protein S. And again, thanks to the dear Dr. Balakrishna, Dr. Bhavik, Dr. Kaushik, and the great pioneer, Dr. Tapas sir, the real guru who started ROP in our state, doing great job. And our president, who has taken a lot of interest. And last but not the least, Sarmishta Madam, who is really, it was a fast, we had started thinking to make it actually physical at Daspur, but some sort of problem. We made it webinar, and even the coordination of Subhadra Ma'am and Tapas sir and Chikta, who is here, who is from Bali, talking to us. And last but not the least, I'd like to thank Learner people who have taken a lot of care making this nice program. Thank you once again to everyone, and thanks also. Thank you. I just want to say anything, please go ahead.
Thank you, everyone. I would just like to say one thing. Amongst all the screening programs in ophthalmology that are running, maybe ROP is the most important one. Today's talk was it has a high learning curve, as well as it's very inspiring to see people like Subhadra ma'am, Tapas, and all of you, Balakrishna, Sabita, Sasmita ma'am, everyone, Santosh, all of you. Thank you so much. And I think all these youngsters, Shashwat, Chitta, all of you are welcome to our NICU to come and please help the needy, help the preterm babies.
RBSK is also there. I think they can help.
No, but RBSK is there, but then they have to be shifted all the way to, they can come here over to NICU.
RBSK
Yes.
people are doing.
Yes. Thank you so much. And let us wind up. Good night.
Thanks, sir. Good night, ma'am.
Good night. Good night, everyone.
Thank you, Subudhi sir. Subudhi sir was also here throughout the show. Thank you so much, sir.
Thank you. Thank you, ma'am.
Thank you, ma'am. Good night, everyone.
Good night.
Thank you so much. Thank you so much, everyone, for giving us the opportunity
Thank
to
you
host
all.
the
Good
session.
night.
Thank you,
Thank you.
Clarinet, for the platform.
Thank you, ma'am. Thank you. Good night, everyone.
Good night.